Hello, my name is Dr. Don Schiller, and I'm speaking with you from Olympia Medical Center in Los Angeles, California. I'm going to talk with you about the options available for people who need to have their entire large intestine, their colon and rectum, removed. The usual conditions that lead to this surgery include ulcerative colitis and familial polyposis. Colitis is an inflammatory condition of the colon, and sometimes medications will not relieve the bleeding and pain and symptoms. If your entire colon and rectum need to be removed, you have three options. One is to have a conventional, what we call a Bruch ileostomy, where the intestine is brought out the abdominal wall. It protrudes above the skin about 3/4 of an inch, and you have to always wear a collection device, which we call an external pouch, or an ileostomy appliance or bag over the stoma. There will always be flow of intestinal waste and gas because the small intestine is a continuous flow system. The second option is the ileoanal J pouch. Here, the lower part of the rectum and anal canal is preserved, and an internal pouch is made from your small intestine and connected to the anal canal. Here you get to go to the bathroom the normal way. You don't need any supplies or equipment. But the range of bowel movements per day is from 4 to 7 every day. And once you get the urge to evacuate, you may only have 45 minutes or perhaps an hour before you will have to evacuate or soil yourself. The third option is the continent ileostomy. For many years, I've been performing the Barnett continent intestinal reservoir, what we call the BCIR, and I'll explain this picture in a moment. The Barnett pouch is the modern day version of the original Kock Pouch continent ileostomy. The BCIR is an internal self-sealing pouch. It has a valve made from your own intestine. It won't allow water in if you go deep sea diving, and no gas or waste will come out of your stoma, only a little bit of mucus, so you only need to wear a small patch over the stoma. It's placed low on the abdominal wall, just above the pubic hairline, much lower than a conventional ileostomy. Several times a day, and the range is from 2 to 6 or 7, the patient will go into the bathroom, painlessly insert a tube or catheter into the pouch. The waste drains automatically into the toilet receptacle. Then you take the tube out, put your little patch over the stoma, rinse out your tube, and you're good to go. Once you get the urge to evacuate, you can wait many hours, although you will feel some pressure and cramping and bloating, but no gas or waste will come out of the stoma until you intubate. That's the process of putting in the tube. I found over many years that the BCIR or Barnett pouch gives patients great freedom, and it gives them complete control over the discharge of their intestinal waste. It's never going to be the same as before the colon was removed and before the colon condition affected you, but you will have a life where you'll have no limitations. Thank you for listening to this presentation.